Hi, this is Louie Puentedura from Las Vegas. I'm here at UNLV in my office. A little out of focus, but anyway. And I'm going to be talking to you about pain neuroscience education and combining it with manual therapy. This is a presentation that I gave at the International Spine Pain Institute annual clinical conference in July in Minneapolis of this year. Okay. So this is kind of a summary slide, sort of what I'm going to talk about. And it's basically that if we think about it, pain neuroscience education is considered one of the best approaches for patients who have chronic pain. Okay? And no one would argue with the fact that people with chronic pain need to understand their pain and that it may have actually little to do or nothing to do with their tissues, their joints, or their muscles. Trying to convince people that pain, they have a pain problem rather than a tissue problem, because tissues heal, and if they've had back pain for 8 or 9 years, it's really shouldn't be that much of a problem in the back anymore. It's more of a pain problem. When we use manual therapy on people like this, it may seem counter to the points we've just discussed, right? That if people don't have a tissue problem, then why are we doing manual therapy to what we presume to be as a mechanical problem with the tissues? Now, my personal history of manual therapy began in the 1980s, and in this medical model of pain seemed to work very well for me. I would have patients who have a lot of pathology and they'd have a lot of symptoms, right? And the symptoms and pathology seemed to be proportional. And it was basically the application of an intervention that would change the pathology, and then the symptoms would decrease, right? It seemed to work fairly well for me back in those days, but perhaps it was because the majority of my patients presented with what was primarily a nociceptive-driven pain mechanism. And the interventions, the manual therapy interventions that I did, actually changed the nociception and got the pain to be better. But the problem was that I began to see a lot of patients whose pain was not primarily nociceptive-driven. All right, they had body charts that looked like this, and they seemed to have a lot of symptoms, but I really couldn't find a lot of pathology. And so instead what they had was more centrally sensitized pain states. And so suddenly our model of pain, symptoms being related to pathology, didn't work. And so around the early 1990s, there was a new branch of manual therapy that seemed to emerge. It was called neurodynamics, and it appeared that we had a new way of treating those other manual therapy type patients, but it really wasn't enough. And then pain science took off, and very soon it looked as though there were two divergent streams for seemingly two different patient populations. You either had a patient who had primarily a mechanical problem, so you did traditional manual therapy, or you have a patient who has primarily a pain problem, so you don't do manual therapy, right? You do P&E. But my question I want to ask is, do they really need to be separated? This is the mature organism model. I'm sure you've all seen it, from Louie, and I hope it's changed the way you see pain like it did for me. What it emphasizes is what we all know with absolute certainty. Pain is an output. Pain is an output from the nervous system or the brain in response to actual or perceived threat. Now, we can alter threat, therefore we can alter pain. What the model showed us was that we can treat patients from a bottom-up approach, manual therapy, motor control, and exercises that would reduce input into the system and thereby reduce pain. Or we could use a top-down approach with pain neuroscience education, P&E, and psychosocial interventions. We can get the patient to cope with the nociception, cope with the problems, maybe they didn't have nociception, and feel better about their pain. But maybe it shouldn't be or. Maybe it should be rather an and, okay? I wrote this narrative review with Tim Flynn last year. We wanted to point out that because the aim of P&E is to shift the patient's focus from the tissues in their low back as a source of their pain to the brain's interpretation of inputs. There are many clinicians that would mistakenly believe that P&E should be hands-off, that it should be education-only type approach. But Manual therapy has been shown to produce local mechanical effects, and providing manual therapy within a P&E context could be seen as meeting or perhaps enhancing our patients' expectations. Maybe we can refresh or sharpen body schema maps in the brain with the use of our manual therapy. Let's explore this a little more. This is a picture of Steve Schmidt. He's one of the instructors at ISPI. Really cool guy. He did his manual therapy training in Australia, so that makes him a cool guy, doesn't it? Yeah. He's about 6'7" tall, and this is just a funny picture that has an overlap so you can see his homunculus in his brain. And the question is, can we sharpen can manual therapy sharpen Steve's homunculus, or more precisely, can manual therapy sharpen our patient's homunculus? What do we mean by that? Well, there's this beautiful metaphor to explain the changes within the brain, the smudging within the brain that's associated with chronic pain, and it was put forward by Karen Litzy. So thank you, Karen, for this wonderful slide and this metaphor. What we do is we ask our patient to compare the details of this Caravaggio painting of a boy right down to the definition of the fingernails you can see on the hand of the boy, right? So this is the sensory part of the brain. This is what the sensory part of the brain sees when it's firing at full strength. When everything is good, life is good, there's no problems, everything is really sharp, we can really know where every body part is. Then we ask our patient to compare this Picasso painting where the outline of the body is much more difficult to make out. Everything seems to be obscured and you can't make out the exact outline of the body. You need to look really carefully to see that it is a female, presumably, playing the lute instrument, right? And this is what happens to your brain when you have persistent pain. The brain can't seem to make out a clear representation of that body part, and it may explain why pain seems to move around, because the brain's not really sure where it should produce pain, okay? Now, there are certain things that we can do to address smudging in the brain. Absolutely, right? There's evidence that suggests there's a place for laterality training, teaching people left and right. 2-point discrimination is at 1 point or 2 points. Sensory awareness retraining. And then graded motor imagery. All of that, seems to work very well with patients who have chronic pain. But what about skillfully delivered manual therapy from the comforting hands of a therapist when we do our central PAs? Could this be a way of resharpening or fixing problems with smudging within the brain? So Adrian and his colleagues, Adrian Louie and colleagues from St Ambrose University, conducted this really interesting randomized control trial that suggested that manual therapy, and in this case it was a grade 2 PA MOB, to the low back could actually be treating the primary somatic sensory cortex. What they did is they got 62 patients with chronic low back pain. Their mean age was about 60, mean duration of symptoms 9.5 years. They measured low back pain and leg pain with a numeric pain rating scale, the Oswestry Disability Index, the Fear Avoidance Belief Questionnaire, and they assessed how much forward flexion they have, fingertips to floor, and straight leg raise with the goniometer. And this was measured before and after a manual therapy intervention, and the manual therapy intervention was a central PA grade 2 to the lumbar spine. Now, the 62 subjects were randomized into one of two groups, either an experimental group or a control group. The experimental group were given a neuroplasticity explanation for the manual therapy technique they were going to have. So they were told the story something like this. See this picture? This is a picture of your brain, and there's a homunculus or a body map in your brain. It's a complete detailed map of where all the body parts are in your brain. Now, when you have pain, these maps become a little smudged, and so your brain's not completely sure that that's where your fingers are, this is where your hand is, this is where your back is, and so on. We're going to do this technique on your back so we can sharpen up the homunculus in your back. So I'm going to push on your back, and I'm going to tell you where I'm pushing, L1, L2, or L3, and get you to verify and tell me which way I'm pushing, so that once I've told you a couple of times, you can then tell me which way I'm pushing it. It's an exercise to resharpen your brain. Okay? The control group were given a biomechanical explanation for the manual therapy technique. See this is a picture of your lumbar spine. There are 5 lumbar vertebrae and then your sacrum, and there are discs in between. And when life is good, when you don't have any back pain, each of these joints move just a little bit. They give you just a little bit of movement. They all contribute to the overall motion. Okay, but when something goes wrong, when you have pain, one segment may not be moving as well as the others. So we're going to do this technique to just get that segment to move more freely so that overall you get better movement, and that should reduce your pain. So two different explanations for exactly the same technique that was done with these patients. All right. Now the results, unfortunately, there was no significant difference between the groups for the outcome measures, except for the straight leg raise. But that was quite surprising that there was a difference in straight leg raise. The experimental group had better increase in the straight leg raise after that intervention. Now, it's interesting that they just had this explanation. I worked with Jeff Maitland in the early 1980s when I was doing my manual therapy graduate diploma, and I used to see him treat patients and was always amazed with the way he would talk to patients. Listen to the way that Jeff interacts with this patient with neck pain. This patient had neck pain and pain in the supraspinous fossa, and just watch how he talks to him as he does these assessment and treatment techniques.
To C5. How does that compare there with if I do the same thing down there?
Actually, the second one's worse.
There? Should I go higher or lower?
No, that's nearly the same pain as I get.
Where? In the neck or down in your
No,
supraspinous fossa? In the neck?
Just in the neck.
If I press harder, is it still just in your neck?
Yep.
How does that side compare with that side?
Isn't that a beautiful way to communicate with a patient and getting them to feel where your manual therapy is being approached and where it's being touched, right? And in a new paper that we presented in Journal of Manual Manip Therapy, we wanted to build a case for a clinical perspective on the P&E approach to manual therapy. And you've all seen this image before about the nervous system as an alarm that's activated in response to an injury or a threat, and how in some patients, all right, those with chronic pain, the system never really returns down to its normal pre-injury or pre-threat resting level. The system remains extra sensitive, right? Well, we can view our manual therapy techniques, manual therapy interventions, as graded exposure. Heck, we even use graded mobilizations, don't we? And the aim is to tease it, touch it, nudge it, and create space for more activities, creating a window of opportunity for our patients to experience movement and exercise without igniting, without reaching the firing level, without igniting their pain. We can view our manual therapy interventions as not just loosening a stiff joint, but helping to sharpen the map of the brain. Why can't we ask our patients during our mobilizations to tell us where we're pushing? Is it high or is it low? Is it the right side or is it the left side? Which way am I moving? To the left or to the right? How deep is the pressure, or how firm is the pressure? Is it light or is it hard? There's plenty of evidence to suggest that manual therapy and manipulation has neurophysiological effects. This interesting study by Sampath and others from New Zealand found that the sympathetic nervous system changes following spinal manipulation are associated with supraspinal mechanisms that control pain, and in particular, structures such as the anterior cingulate cortex, the amygdala, the periaqueductal grey area, the rostroventromedial medulla, cerebellar vermis, and all of these are implicated in manipulation-induced anesthesia with concurrent autonomic effects. This is an image from their paper that suggests that spinal manipulation as an input will set up this cascade of events within the supraspinal centers that results in reduced pain. There's autonomic activation and opioid-independent analgesia, or endogenous release of analgesic type events. This is another study by Laura Timon and others, and they use EEG, electroencephalograms, to compare bottom-up and top-down mediated modulators of pain. They found that stimulus intensity, which was a bottom-up modulated pain-evoked potentials, produced pain-induced alpha and gamma responses. But in the placebo analgesia, the top-down mechanism, this is more associated with changes of evoked potentials, but not in alpha and gamma responses, right? So what they found was pain-related neuronal responses were differentially sensitive to either a bottom-up or a top-down modulation of pain. And the key finding here is that the pain-related changes were complementary, right? They can work together, bottom-up and top-down. And finally, this is a recent literature review related to supraspinal mechanisms associated with pain and pain inhibition following spinal manipulation, and how it consistently involves specific brain areas. Again, the amygdala, the anterior cingulate cortex, the thalamus, insula, cerebellum, primary and secondary somatosensory cortices, the periaqueductal grey area, or the PAG, and the dorsal horn, and all has shown to become activated in response to pain, with subsequent decreased activation following joint mobilization or joint manipulation. A really cool study. So, coming back to our patient with chronic pain, where we may determine that tissue injury or damage is not really a significant cause of their pain. There's a lot we can do, and we often, our research group, refers to what we can do to these patients as P&E plus, right? There's the education, pain education, absolutely, P&E. Plus, we also have to do goal setting, sleep hygiene, and aerobic exercise. We refer to these as cardinal requirements for a P&E approach, that we have to have pain education, some sort of aerobic exercise, get the patient moving, attend to sleep hygiene, and set appropriate goals. But then there's other things that you can do. And one of the things we can do is manual therapy. All right? It's one of the options for our patient. It's not off the table. And we can ask our patient, okay, these are the 4 things we have to do, but you can choose the others. Which would you like to do? Well, I'd like to try some humor, or I'd like some soft tissue or trigger point therapy. I'd like some dry needling, or I feel really good when my neck and joint, my joints are popped. I want some manual therapy. That's all great. We can do this. It's not off the table. At the conference, Siobhan Shabram from Australia talked about sensory input, and this is some tweets from the conference, ISPI 2017, where Corey Zimney said, sensory input is the most powerful driver of neuroplasticity. And this is, again, from Siobhan Shabram, sensory input being the most powerful driver of neuroplasticity. If we want our patients to change, if we want neuroplastic changes in their brains to manage their pain, then we have to have some appropriate kind of sensory input. And what is manual therapy other than a sensory input? So that concludes the talk. Thank you very much. I'd like to acknowledge a lot of people I work with that help me with research, and I hope you found the presentation useful. I'll see many of you, I hope, very soon when I come and teach the Pain Neuroscience Education course in Chile. Cheers!